This is a University of North Midlands training video for healthcare professionals working in obstetrics. It will cover the significance, prevalence and cause of antenatal anaemia, and by the end of the session you should be familiar with the UHNM antenatal anaemia flowchart and be able to identify women at risk of or with iron deficiency anaemia and manage them appropriately. Anemia is bad for the mother and for the baby. Pregnant women who are anemic are significantly more fatigued, they're more likely to suffer from postnatal depression and experience postpartum hemorrhage. Maternal anemia is also associated with increased morbidity and mortality in the baby. The word anemia simply means that the haemoglobin concentration is below a defined level. Haemoglobin is the oxygen-carrying component of red blood cells. Haemoglobin concentration, or HB, is measured as part of the full blood count. Red blood cells are smashed up and light is shone through that haemoglobin soup, and the amount of light getting through gives you the haemoglobin. During pregnancy, plasma volume increases by up to 45% in the third trimester, naturally diluting the woman's haemoglobin concentration to help her body better cope with the increased bleeding risk at delivery. The World Health Organization defines anemia according to the woman's gestation and their haemoglobin concentration, as depicted in this image. Anemia is a huge problem worldwide, with almost every other pregnant woman being anemic, rising from a baseline of 1 in 4 menstruating women being anemic. In the UK, studies have found that at least 1 in 4 pregnant women are anemic. By far the most common cause of anemia in pregnancy is iron deficiency. This is due to the increased demands for iron and folate to make maternal and fetal red blood cells. In fact, it's impossible in the later stages to take adequate oral iron in your diet to keep up with the requirements of pregnancy. For this reason, all women should be given advice on how to increase the iron content of their diet. Foods rich in iron include meat and fish, but also eggs, fortified cereals and leafy green vegetables. It's important to provide women with written advice as well as verbal advice, and patient information leaflets are available. Anemia and/or risk factors for iron deficiency should be identified at booking and documented in the woman's medical records, K2. They also need to be acted upon. Alternatively, anemia may be identified on routine bloods at the 28-week check, and women carrying multiple pregnancies should have an additional full blood count done at 20 weeks. Booking is also a very important time at which we can identify women who are at highest risk of iron deficiency, so that prophylactic or preventative iron can be started to prevent the woman from developing anemia. This includes people with a personal or medical history that increases their risk of iron deficiency. So this might be people with a previous history of heavy periods, those people who have got a very poor dietary intake of iron, but it's also obstetric reasons that increase the iron demand, for example, having pregnancies very close together. Women who are found to be anemic, either at booking or 28 weeks, should be advised to start a course of oral iron as ferrous sulfate 200 milligrams each morning. This can be obtained either via the GP or bought over the counter. Absorption is improved by taking the iron in the morning on an empty stomach with a glass of orange juice. It's also important to tell people what to avoid, so tea, coffee, dairy products, as some factors prevent the iron from being absorbed. Our body struggles to absorb iron, and actually taking iron 2 or 3 times a day increases the side effects, but doesn't actually increase the amount of iron absorbed. Studies in non-pregnant women suggest that taking iron on alternate days may actually increase the percentage of iron absorbed, and this is to do with hepcidin. Like a lot of things in life, more oral iron is not always better. All women started on oral iron should be instructed to contact their midwife if at a week or at any time during their treatment they are unable to tolerate their oral iron. Midwives should advise according to symptoms. Patients with constipation should be advised to take laxatives like lactulose, and those with upper GI symptoms should be advised to either reduce the dose or reduce the frequency of oral iron supplementation. 2 to 3 weeks after starting oral iron, a repeat full blood count must be done to assess the response of the haemoglobin to this treatment. At this time, it's also appropriate to see whether they're compliant with the recommended dosing and whether they're tolerating the medication okay. The frequency of full blood counts after that will depend on the haemoglobin and the patient clinical situation. Those women tolerating and responding to oral iron should be advised to continue the treatment for at least 3 months and a minimum of 6 weeks postpartum. In women with a haemoglobin less than 70 grams per litre and or significant symptoms of anaemia, an advanced gestation with a haemoglobin below 100 should be asked to continue on their oral iron and a referral made to the Joint Haematology Obstetric Clinic. Those women who show an insufficient response to oral iron, so that's a rise less than 10 grams per litre in a couple of weeks or less than 20 in 4, should have anemia screening bloods requested and again a referral sent to the Joint Haematology Obstetric Clinic. The screening bloods are all detailed in the guideline. For most women, iron deficiency is diagnosed by a therapeutic trial of oral iron. If, however, the diagnosis is in question, the woman has a known haemoglobinopathy, such as thalassemia, or the woman has a less than ideal response to oral iron, then we use a serum ferritin as our marker for iron deficiency. Ferritin reflects your iron stores, and so if your serum ferritin level is low, then it shows that you have absolute iron deficiency, period. The trouble is that ferritin is an acute phase protein, so it goes up in times of inflammation and infection. Intravenous iron is indicated where there's laboratory evidence of iron deficiency and oral iron preparations are either ineffective or inappropriate, or where there's a clinical need to deliver iron rapidly. At UHNM, the intravenous iron formulation we use is Monifer, which can be given in a single infusion of up to 20 milligrams per kilogram. Intravenous iron is safe for the mother and the baby during pregnancy, although must be avoided during the first trimester. The risks and contraindications to intravenous iron are clearly outlined in the UHNM Monifer prescription, and all women should have appropriate consent for the common hypersensitivity reactions, as well as skin staining and delayed sensitivity reactions. On the Trust intranet, under Blood and Blood Products, Iron Support Tools, you can find the prescription chart, patient information leaflets, and also a hypersensitivity reaction algorithm that demonstrates what to do if someone develops any signs or symptoms of a possible reaction. Most of these respond to stopping the infusion and giving it more slowly. After delivery, it's only necessary to repeat a full blood count if there's a history of uncorrected anaemia antenatally, more than 500 ml of blood loss, or where the woman is symptomatic of postpartum anemia. If there's ongoing severe bleeding, you need to transfuse red cells as dictated by the clinical situation and refer to the ASQUAM postpartum hemorrhage guideline and ROTEM major obstetric hemorrhage pathway. If the haemoglobin is below 70 grams per litre, or if it's below 80 and the woman has moderate to severe symptoms of anaemia, then you need to administer intravenous iron and consider a single unit of blood transfusion where clinically appropriate. Transfusion is safe, but not without significant risk, and the decision to transfuse is based on more than blood test results. With transfusion, like oral iron, more is not always better. Remember that each unit transfused is a treatment decision, and that most women can be well managed with intravenous iron. Multiple randomised controlled trials have shown us that adopting a restrictive transfusion threshold reduces exposure to blood components without clinical detriment. Transfusion exposes women to the risks of acute transfusion reaction, antibody formation that can impact on future pregnancy, and prevents them from being a blood donor. Anemia is diagnosed in pregnancy by a haemoglobin less than 110 grams per litre in the first trimester, less than 105 in the second and third, and less than 100 grams per litre postpartum. Anemia affects more than 1 in 4 pregnant women and leads to worse morbidity and mortality for both the mother and the baby. In 9 out of 10 women, the cause of anemia is iron deficiency, and for that reason all women need to receive verbal and written advice about how to increase the iron intake of their diet. Iron deficiency anemia is both confirmed and treated simultaneously through the ingestion of 200 milligrams of ferrous sulfate each morning, although a ferritin should be checked to confirm iron deficiency in women with the diagnosis of a haemoglobinopathy. In those women who are at increased risk of iron deficiency but have not yet developed anemia, they should be given ferrous sulfate on alternate mornings to minimise anemia development. Intravenous iron is a safe and effective alternative to oral iron outside of the first trimester and should always be used as an alternative or an adjunct to blood transfusion. Further advice on the diagnosis and treatment of iron deficiency can be found in the national guidelines, local guidelines, and online support tools.